I think some of the challenges that we faced prior to having Viz AI as our solution was how do we see the images at some of our spoke centers when we didn't have access to them? How are we going to get relevant information, especially as we do integrations? You're integrating multiple EHRs together and you don't have access to everything. So I think those are kind of some of the biggest challenges, as well as the regulations that we are held to from our governing bodies, whether it be Joint Commission, DNV, American Heart, American Stroke, get with the guidelines, and how do we provide high quality, efficient care?
Great. Karen, what are your thoughts?
I echo everything that Jayme just said. And thinking a little bit bigger picture, just zoom out for a second. We have a wide disparity in who has access to the kind of care that we want to provide. So as administrators, we feel a responsibility to not just our community, our catchment area, but also, as Jayme mentioned, we're very frequently bringing people from hours and hours away to have comprehensive neuroscience care. So how do we get those resources to those people? How do we decide who we can bring into our systems to provide that care? And using artificial intelligence is a bridge to try to bring that completely, that neuroscience expertise and all of those surrounding benefits from having the diagnosticians and the ability to read the images and the ability to communicate seamlessly to say, I can be in a very, very geographically challenging area in a healthcare wasteland, and I can get the same care as if I was in the middle of the wealthiest city in the world right next door to the comprehensive center. So my job as an administrator, my challenge is to provide those resources, to select the resources. And then, and I would say lastly, we're doing this in a pandemic. We're doing this in a recovery where all of our resources are very limited.
Yeah.
I'd say pretty big challenge.
Absolutely. And Wendy, I know you've been part of two very big systems, obviously Florida Hospital in Orlando and now Boca Baptist. What do you feel, based on your experience as well, has been your biggest challenge as a neuroscience administrator? I would say kind of as it's evolved, you know, from before the pandemic and current state.
I wanted to make sure nobody heard me. You bring up a great point. And, you know, where I am currently at the Marcus Neuroscience Institute, we're fairly young. You know, we're a young institute. It's only been established for the last 5 or 6 years. And where I was before, I mean, it had been established and we were continuing to grow and to work. And I think they bring different challenges as an administrator. You know, having an established program, obviously you have to keep up with technology. You have to keep up with resources and looking at what's out there because, you know, like Karen said, you know, we want to be able to provide the best resources and the best care in a large system that doesn't always have it available on the campus that they're closest to. So how do we organize that? But when I looked at what's going on here at Boca, at the Marcus Neuroscience Institute, you know, we've had to start from scratch and we're continuing to grow and build in a very rapid fashion in an environment that, you know, like you said, with the pandemic, but our providers still worked. We pivoted very fast. We still saw patients either telemedicine wise or even brought them in, but being able to provide that great care and keeping up with the staffing issues, you know, we're all facing those. And when I look, you know, from a macro level, you know, the staffing of, you know, just MAs and nurses has been, you know, crazy to try and keep track of. And then as we're expanding into the north and to our 2 other campuses here, you know, being able to find neurologists, you know, that's such a challenge for us. Neurosurgeons, you know, are easier, but just finding neurologists that want to provide care and being in an aging population all over, not just Florida. I mean, everybody wants to come to Florida now and nobody went home this year. So they're still here, you know, so how do we provide care for those aging individuals that need the progressive care that we have to that we have to provide. And then, like I said, technology, there's so many fun things now for neuroscience that in the past we were just the touchy-feely, type of departments other than the neurosurgeons. But now, I mean, we have biplanes and robots, and, now we have drugs that are like coming to the forefront for Alzheimer's, so there's just so many things for us administrators to keep track of and to make our patients and our staff and physicians accountable, responsible fiscally, but also being able to, to manage that and work as a team.
Well, we're definitely going to talk about, fiscal responsibility, but that's a good lead into my next question. I think, the beauty of technology and how it's evolved, especially in the world of AI, is how it's been impacting healthcare. And I'm curious for all of you, how did you actually get your organization to support or buy into AI or stroke software? Was it easy? What steps did you have to go through? And what do you recommend for the group? We'll start with Wendy again.
So I think, we already had some technology that we were using, not AI, but we were using technology that was around for a long time as we were doing some of the stroke trials. So having the technology that looked at large vessel occlusions and other scans was not unfamiliar. Where our challenge was why do we change? This is working. Why do we need something else? And so we needed to be able to convince our providers and our team that, this was something that they needed to look at, because not only did it, show the scans on their email, or they could pull it up on their phone if they had email, but this actually had the opportunity to notify everyone that there was a potential that we needed something more than just TPA, or something more, in care coordination. So we did a side-by-side trial, and Lisa remembers this.
Oh yeah.
And basically we had to look at who the stakeholders were, and what one division liked was not necessarily who the stakeholders were that were going to be providing the best care. So I think it just came down to, the communication component was a huge factor for us, and being able to notify the team fast and get everybody there. And not necessarily all standing in one room in the CT scan with 26 people in the room. You could communicate without having everybody physically present.
Right. That's great. I mean, I feel like I've been on the journey with all of you. Karen, what are your thoughts? How did you get buy-in from your leadership, and what did that look like?
Well, this is the second organization where we've implemented Viz. So I had experience going into Atrium Health with this, and I will say that I really focused on the clinical benefits. So when I looked at what I could offer the organization, I really had to say I have the ability to shorten length of stay. I have the ability to be a better steward with our resources. So convincing an organization that's bringing patients from upwards of 40 different hospitals, who do you bring? How do you know to bring them? So having a technology that helps you make that decision and bring the folks who really need tertiary or quaternary care to your comprehensive center, that was a huge selling point. And also being able to look at what's going on clinically in a patient by reviewing their imaging, or currently looking at a hemorrhagic stroke, we can say, this patient doesn't need to transfer, or they don't need critical care, or maybe they don't even need to be admitted. They just need observation. But before, was pretty much like all of the organizations, a blanket process. If there's blood in the brain and they're at an outside hospital, they're coming to the comprehensive center. So shorter length of stay, the ability to move patients through the system, even the ability to say these patients don't necessarily even need to be managed in the ICU. So all of that information at your fingertips, where people can share the information using the communication component, and then also be able to view the images remotely, easily. We have a full complement of neuroradiologists, and we would never say this is a replacement for those neuroradiologists, but it really became a tool, and the idea was this tool could make people's lives easier.
Great. Jayme, what would you say that your process was similar as far as getting buy-in from your administrative leadership, or how did it differ?
Ours was a little bit different, and I have two separate experiences. So similar to Wendy's experience, having used a previous technology when I was at Baptist Health South Florida, before the integration with Boca, we had to do the side by side and kind of do a comparison together to really get the buy-in from all the stakeholders. Like, hey, well, the AI is great and the AI is fantastic and it raises that awareness. What really was magical was the ability to change and disrupt the workflow, because all of the sudden we had this tool that not only just gave us AI and notification and alert, like, hey, look at this patient right now, but it was, hey, now we're going to cut all of these processes out of the way to streamline workflow and implementation to get the patient to the right center for the right treatment at the right time. And I think when I came to Piedmont, having had that experience where we transitioned from one technology to the other, and when I got to Piedmont, we were a baby program. I mean, we were just starting right there. We had really good foundational stroke systems of care for primary, but really didn't have that foundation for comprehensive stroke workflow. And we started the process by getting the buy-in from all the clinicians, and similar to what Karen has said, and looking at the quality and what the impact is. You know, we're clinicians at heart, so that's always the top of mind. But then also having to do the financial ROI and say, look at the impact that this can make. And we had some really good evidence that had been out and came out of multiple centers. And from my previous experience as Baptist, so we were able to say, we can shift these patients from medical management to these surgical management, these DRGs. We can keep patients where they are and not transfer them. And since our implementation at Piedmont, I mean, when Viz is used and Viz is used consistently for the whole care coordination, we see significant changes in outcomes for better, reduction in length of stay of 2.2 days in the ICU, 45% of our patients going home versus none of our patients going home. Like, it's really impactful. So I think when you have the quality and the financial, it's a win-win for the organization.
Awesome. I think most of you already sort of answered my next question, but it's really about, you have all been using AI technology for some time now, and most of you have been using Viz probably for a good, 2+ years. What benefits have you seen? And I think, Jayme, I'll start with you, specifically as it relates to healthcare economics around NTAP. If you can talk a little bit about, the financials and how you've been able to utilize NTAP at your center.
Yeah, I think the NTAP is really impactful for the spoke sites and out into those communities where there are these vulnerable populations that need access to this life-saving technology. You do get the financial benefit when those patients get transferred and come into the hub, because you're doing those high volume, high kind of margin procedures. When they stay within the communities and there are those medical stroke DRGs, because we don't have a quick solution to transition them through, they're not maybe always improvement in having a longer length of stay. The NTAP really puts that layer in of additional support to help the organization offset the cost for the technology. So it's been really impactful to be able to go back to the CFOs of the organizations and say, hey, look, this is what we've billed for, this is what we've collected on, this is how impactful this is. Mm-hmm. And now there's a benefit and an ROI associated with it. And I think also layering in those things that we talked about, like our time to treatment, door in, door out, we've saved 69 minutes, our ICU reduction in length of stay of 2.2 days, all of those things then help drive the economic impact of a technology. And I think, I don't know, we were all early users, and I would ask Wendy and Karen the same. I don't think any of us thought when we initially implemented that there was going to be this huge economic impact. We knew quality is what we needed, but then all of a sudden we're like, well, what's going on with our length of stay? It's reducing, our time to treatment is down, and then starting to tie those pieces back together.
Awesome. And I think, Wendy, you've had a similar experience. If you can share with us sort of, how you started with the NTAP process and where you are today, from, a revenue perspective, and how that's attributed to actually being able to help you fund the cost of the software.
Yeah, so like Jayme said, we all adopted this well before we even knew what the NTAP was. And, still everybody's like, what's NTAP? And so if you don't know, look it up. And so with saying that, when it started, we set up our team and we're like, okay, we're gonna work this through. We're gonna get everything situated. So we have our coding down, we have our processes down. We even did like a little caption so that we could pull it from our EMR to make sure that the coders had it in there so that we could bill for it. We started October 1st. And as of the 15th of July, I could cover 10 campuses right now. And that's the amount of money that we've gotten back from NTAP. So right there, it covered my cost for here. It covered my cost for the 2 facilities we have in the north, and even more for years to come. So, everybody's just excited and actually looking at this as such a benefit from a financial standpoint. I mean, what kind of equipment or technology can you use where you actually get money back for using it?
Yeah. Can you talk to, as far as the implementation of NTAP, what did that look like for your team? And did you oversee that, or who managed that process for you to be so successful there?
So it was a team. I mean, it wasn't just me. We just got together and with our biz rep and Stephanie, who was really instrumental in working with us to begin with. And thank you very much for taking her away from me, Stephanie. But we just sat down and said, how can we do this best? We wanted it to be a system that was easy, and we didn't have to ask our technicians to plug it in or our coders to have to figure it out. So we just automated it. And, we had IT involved, we had, our techs involved, we had our HIMs involved, our coders involved, and we just figured it out. And it was great to see the results come up so fast.
Fantastic. Thank you. Karen, I'm interested in knowing, obviously, Atrium is a big program. You have a lot of spoke sites. Can you share with us, your experience around the clinical impact so far?
Sure. And just to add on, one of the benefits of working with Viz was their communication around NTAP. So obviously that wasn't there when we all made the decision to go with Viz. And
right.
It really was seamless, and all the information we needed for our coders was provided readily. I know Jayme was doing webinars and teaching us about it, so nobody would want to know what is NTAP, because we all now know very well. So I will say that was a benefit to working specifically with Viz. For clinical outcomes, we alluded to that earlier. We talked about things like reduced length of stay. But one of the things we don't often think about is bed availability. And if you are able to identify a patient with a large vessel occlusion sooner, and they are eligible then for treatment, and you have a successful thrombectomy, then first of all, your patients clinically will do better. They will have much improved discharge disposition. You mentioned many patients going home, or some now being eligible for acute rehab, but you also open up beds for patients to come to your facility. So you're increasing your number of procedures, you're increasing your number of discharges, you're decreasing 30-day mortality, you're decreasing in-hospital mortality, because you have patients that previously would have not been identified as quickly. They would have been out of the window of eligibility, or they would have had, essentially no mismatch, and then you're going to put them in the ICU on hemicrania watch. So you're there for days and days. You're talking about hospital-acquired conditions, so you're reducing your hospital-acquired conditions. So it's really like a wheel that just spins with all of the benefits. And it all starts with the early identification, with the clinical information, with the ability to communicate that information quickly. And I feel, as a resource, we have a responsibility as the comprehensive center and as neuroscience administrators to make that available to hospitals who don't have those resources. We even provided this year, Atrium provided brand new telestroke carts across the entire Carolina Stroke Network, even for folks who aren't part of our system, but who rely on us to provide the clinical expertise, because we want everyone using this technology, right? We want them to be able to take that in, get it in, share information, evaluate the patients, push us images, rapidly, so that we can see everything going on and make those decisions. So clinically, it's impossible to do any better. Now, I will say a new benefit, again, is the ability to identify those hemorrhagic stroke patients. And something else that we're looking forward to are the other opportunities, even clinically, being able to use the imaging. I know some of you used it during COVID for some of your pulmonary, for your lung imaging. So being able to think about the future of how we will use the technology opens even more possibilities for better clinical care.
Awesome. I think, you know, I've been with Viz for almost 3 years, which is hard to believe. And I think when I first started, and, you know, the whole evolution of AI and stroke and the ability to impact stroke workflow just blew my mind. And I think today where we are is incredibly exciting because we're venturing into, you know, other disease states that are time dependent. So I think my next question for you ladies is, where do you really see AI impacting not only in the neuroscience space, but as we evolve in healthcare? Where do you think the biggest impact in AI will be? I'll start with Jayme.
So I think if we kind of stay within neuro, I think some of the things that really are going to be impactful is aneurysm. So I think we leak and lose a lot of aneurysms, whether it's an incidental finding, you know, it's caught later when the neuroradiologist goes back and redoes the report and the patient's already left the hospital. And now we've lost them and we can't get them back in. And we know with aneurysm, considering some of the risk factors that they may have, they may be likely to rupture, which comes with high mortality, high morbidity. So I'm really looking forward to aneurysm and really starting to capture those patients that maybe before we would have lost out into, the community. I think, you know, obviously if it's a ruptured aneurysm, that's a very different workflow. It's not missed, it's found, you know, but these unruptured ones that if they've had previous rupture, if they have risk factors for smoking, family history, they're high risk. And, you know, if we can capture them, get them into the clinics and make sure we keep them in the clinics with their follow-up, it's important. I think I'm also really excited. I saw the announcement about the PE and aortic dissection algorithms, which I'm really excited about because I think of PE where stroke was back, years ago, 10 years ago, and we were just trying to figure it out and get ourselves organized and what were the impacts? How do we treat them? What's the best way to treat it? Is it alteplase? Is it thrombectomy? And I think PE is getting that evolution with the PERT team and PERT consortium and all of the work that's being done around that. So I'm really excited to see the impact and how PE evolves in treatment and therapies, because as clinicians, we've all seen patients with PEs and, you know, it's traumatic to watch on the inpatient side. And if we can find a way to treat them better and treat them faster, I think it would be critical.
Yeah, I couldn't agree more. I'm seeing some of the chats come through and I'm 100% on aneurysms. I cannot wait. It's just around the corner. So somebody was commenting they wish they had it the other night as well as PE. So me too. But we have PE and AD now. So that'll be another webinar for sure. Wendy, your thoughts on AI as it relates to neuroscience and the future of healthcare, as well as AI in general?
So I think AI in general, as I think about it, it's like the brain, right? Because it learns, it takes the learning that it has and it manages it and it learns more and it learns more. So it just makes sense for it to be in the neuroscience world, right? Because of the brain. I think, obviously, like Jayme said, aneurysms, the bleeds that we have, we did use it during COVID and it was exceptional. It wasn't from an AI perspective because I mean, Viz came up with this very, very rapidly. So, it didn't have time to learn, but, the communication component of it during COVID, where we would take x-rays of someone's lungs and the whole team would know whether it was, a COVID patient or not. So that changes your whole treatment of that patient, especially if they come in with a stroke or an MI or something like that, because we had a whole different process with our COVID patients during those initial stages, and our whole intubation process, we would have to do them in the ED as opposed to in the neuro suite. So, having that rapid identification of that and not necessarily having the people in the ED having to like surround it and call people and, using the phone and saying, no, they're COVID, bring them back in. And we have to, to do the PPE component. I think there's so much ability now around spine, and I'm excited to be able to be able to get a hold of that really, really soon, because we know that we lose a lot of our back pain patients that come into the emergency room because of a differential diagnosis. You know, they're given pain meds and they're sent to their PCP to follow up because they're still walking, and there's not really that identification of how that spine patient could benefit from a kyphoplasty and not just, you know, brace them up, or could benefit from, you know, seeing a neurosurgeon immediately because of something significant. So, you know, being able to have that from the spine world, I think would be, you know, pretty significant. And then, you know, going outside of the neurosciences, you know, looking, well, not even outside, but, you know, looking at the precursors to some of their chronic progressive disease processes. And, you know, I'm thinking in particular, again, because of the new Alzheimer's drug that just came out, you know, we have to show amyloids in the brain before they're even qualified for that infusion. So, you know, is there a way, you know, that artificial intelligence can tell us if there's amyloid processes other than having to get a, you know, a spinal tap or a PET scan? You know, so the genome testing, I mean, there's lots of things that I'm excited about, you know, everyone being able to learn, and the AI process being able to help identify and predict future symptoms off of this is the way the brain looks today and how they may already be seeing MS, for example, and the myelination and demyelination of the brain coming through.
Right.
Lots of fun, exciting stuff.
Yeah, absolutely. So you would agree that it's here to stay and it just continues to grow. Karen, what are your thoughts as far as AI in the future and around neurosciences?
So if I'm thinking that one of the biggest challenges is going to keep up the momentum that we learned during COVID. So we learned to move in a virtual way. We learned to bring care to the patient. Yeah. Right. So how can we look at that and leverage what we learned from this pandemic, and also some of the differences in how we're reimbursed now for virtual care and getting full reimbursement for clinic visits that are done in the comfort of a patient's home? When you think about the neuroscience patient population, many of them have mobility challenges. Many of them have challenges coming into the hospital. I mean, recently, even with my own family, taking people for visits, having to walk the length of 2 football fields from a parking deck to try to get into an appointment that I could have done in the comfort of my home. So I really feel that we learned a lot from there. We have the ability to be compensated for that care. So how do we continue our consumers? And I say consumers because how many patients have you cared for who see something on the internet or hear something in a commercial and that's what they want? We're seeing that right now, of course, with the approval of our first Alzheimer's infusion. And so we really have to be able to answer that. First of all, the need from the community, but also addressing, you know, one of the things we started doing in COVID was doing EMU monitoring in patients' homes, because these patients needed to be diagnosed, but they didn't need to be in an environment where they were potentially exposed to the risk of COVID. So I think that we need to figure out how to continue the momentum of providing virtual options to our patients.
Yeah, I would agree. I think it's been a tremendous impact in the right direction from a positive perspective for sure. Let me ask you, ladies, there's some questions from the chat. So one of the questions is, who is involved in the decision-making process for new technologies? And how long did it take you to get new AI software at your program? So I'll start with I'll start with Wendy.
So since we merged with Baptist 2 years ago, you know, before that we were an independent hospital. So decision making was very simple. You know, the people that made the decision were finance and the CEO. You know, working for a small organization has its benefits in that regard. You know, you got an answer right away. In a bigger system, there's a lot more levels and a lot more processes. So you have to vet it. You know, you have to approach it as a new initiative, especially if it's over a certain amount of money, and especially if it's IT, then IT needs to vet it and make sure that, you know, it fits within the parameters of safety. And so it could potentially take a long time, depending upon, you know, how the process works and the layers that are in your system.
Fantastic. Jayme?
Yeah, I think you have to, so if it's the organization hasn't implemented any AI or like innovative technology before, I think you definitely have to do a lot of groundwork and a lot of, you know, we call it the road show. So just going around and talking to everybody to get the buy-in at the local levels of all the hospitals and laying that foundational groundwork then made it a lot easier when we went and had to present to, the board and the IT security, committee that we have, as well as all of the CFOs. So it wasn't the first time that they've heard of this. Really thoughtful of how we prepared and presented the information on the financial, as well as, most importantly, the quality impact. It was actually went a lot faster than I thought it would at Piedmont. And there was actually the comment was, we can't believe you got it through that fast. But it was really, Viz was really great in helping make sure they filled out all of our ITIS security documents really timely, turned it around, I would say within 3 days. And it's no easy book to fill out. And then from an implementation standpoint, really was streamlined. I mean, we stood up the whole system in 22 days from time of contract execution. So, and the user experience is so good that it doesn't require that much training, right? It's just, you can get in there and you figure it out, but there's also the training and having the customer success team, who's always so supportive. Daniel's our rep and does an amazing job. So, you just got to do your groundwork and make sure you get the buy-in from who the key players are. And I always like to what would cause this to be at risk and address them up front so you don't hit them.
Well, I think, Karen, I'll let you answer it, but I think I'll tie in one of these questions. So a couple of things that have come up in the chat is talking about the interface between IT security, that being the most difficult, and if you can maybe talk to any of the pitfalls or positive experiences around implementation. The audience would like to know about that.
Sure. So I get to answer 3 questions in one.
Yes.
To address the first question about buy-in and who is involved in the decision. Ultimately, the most important people to involve in the decision are the clinicians who are going to be providing the care. We are talking about their direct life. This is their time, this is their energy. So we were very careful to include neuroradiologists, interventional radiologists, neurosurgeons, our vascular neurologists. Those are my stakeholders, right? So if they can use a piece of technology that's going to then benefit patients, we really want them to be able to touch it, feel it, make suggestions, ask questions. So they were really the key to the involvement. And then it's up to me as the administrator to organize my information to share with the IT and the security and all the committees for approval and the funding and trying to make my case there. But the first piece, the most important piece, was allowing our providers to review and to work with that. I would say things that went well in terms of implementation, and I would say from a technical standpoint, we had already been using a different platform previously. So it was a matter of really changing over, but it wasn't a new process to be able to use an AI application for software. So sure. It was a smooth and seamless transition from one to the other. And being mindful that the technology ran the gamut from the latest and greatest, newest technology to hospitals that still had, a 16 slice CT, somewhere in the basement, a 10-bed critical access hospital. So we really had to be able to make this work across, dozens upon dozens of sites. And then you couple that with the fact that, as of a week ago, before we acquired another system, we had 70,000 teammates, right? So you've got people across all of these different sites, the urgent cares, right? So your freestanding EDs, all of your hospitals, who are going to have to understand what are the protocols, how do we do this, what is important in terms of even positioning and movement of the patient, making sure down to the level of each of those individuals that education was provided. And a positive component to working with the Viz team was that they gave us ample resources. People were boots on the ground, offering much more time and availability that anybody wanted or needed, because they're like, just tell me what I need to know. Yeah. But right. They were there if we needed them, gathering the list and the contact information so that they could work with scheduling all of our stakeholders for their particular training and education, offering to continue to meet with them virtually, still do, if there are questions, asking for feedback constantly. So I think all of those were positive.
Oops.
Sorry.
That's okay. Keep going, Karen.
I think I covered, I don't want to take all the time, so.
So if I can,
Oh, no, that's right.
can I just
Yeah.
interject something? You know, what Karen said
Absolutely.
just stimulated me to think of something in the early days when we were doing the trial and we were comparing, you know, the two products that we had. The one thing that our clinical team were very frustrated about were the false positives. And, you know, the team came and, I mean, we went like second by second trying to figure out what was going on, because they were like, well, see, it's not any better. It just gave them an excuse to not like Viz. And, you know, the team was very instrumental in coming down. And I believe there was a physician and a radiologist that came and a technician and a CT. I mean, it was just like a whole group of them coming to find out, and come to find out it was our protocol and our chin tuck and the way that we were performing our CT scans that were creating the false positives. You know, so the team, you know, was able to identify that, and it really helped us with convincing, you know, the rest of our team here that it was a viable solution, and it was basically our protocols that were creating all the issues. I remember talking to Lisa, and I'm like, you know, she's like, it's only like, you know, 1 or 2%. I'm like, well, why is ours 50%?
Yeah, and that was very interesting, because we spent, you know, a good day or two really just kind of doing an entire system assessment and looking at images, looking at the imaging protocol. So yeah, it was a learning process from the get-go.
So in
for
talking
sure.
about the team support, it was amazing. You know, everybody just pitched in and flew in and, you know, figured it out really, really fast.
I think you guys have touched on this a little bit. One of the questions that came in the chat is, you know, obviously we've all been exposed to different softwares out there. So the question in the chat is, what has Viz given you that other similar softwares couldn't? Jayme, if you want to take that first.
Yeah, I think, you know, we're at this place in healthcare that like there's all these solutions and people are piecemealing the solutions together to generate an the perfect solution, right? So you have a tool for chat, you have your mobile PACS viewer, you have Epic Haiku, right? And you try to piece them together, but it doesn't really do the job because it's not all encompassing in one place. And I would say there's a lot of care coordination kind of platforms out there. However, Viz gives you everything that you need to make a decision about a patient. It gives you the imaging. I am no radiologist or neuroradiologist, but the image viewer is so good. Like I can see the LVO. I know where it is. You can find it. And then you have the image viewer, you have the communication platform, you have the EHR and clinical information. Everything that you need is in the palm of your hands. And I think I had this aha moment when my neurosurgeon, Mike Stiefel, you know, he was on call for the past year by himself, 24/7, 365. And he said to me, like, Viz has made a huge change in my life because I can still have my life on call. Like I can be at my daughter's lacrosse game and I don't have to make sure I have an iPad or a computer or a Wi-Fi connection to be able to get in. I don't have to get up from the dinner table. I can make treatment decisions on the patient while I'm sitting at my dinner table with my family and nobody ever is disrupted. So I think just pulling all of that together, it is the total solution. There's no need to piecemeal together different technologies and platforms. It does serve that universal need, not just for neuro and stroke, but really for any disease state.
Sure. Anyone else want to comment on that?
Totally agree.
Karen?
Yeah, one thing I'd say that I felt with Viz was that when our providers wanted different solutions or they wanted different features that didn't currently exist within the product, that Viz worked with them and actually designed new features for these providers to use because they were used to using some things that they liked to look at separately or you know, having the ability to manually post-process. And they said, okay, well, you know, we'll just do that. and they did. And so I appreciate a company who hears the voice of the customer and who is nimble enough to say, okay, we definitely want to continue to grow and improve our product. And we want to make this something that's better for our providers, better for our customers, better for patients. So we don't just sort of stop and be satisfied with the current profile of offerings. So that's just one of the positives to working with this.
Perfect, thanks. Another question that comes up in a couple different ways is pre-hospital. Obviously, we know with Viz, we've tackled the time to imaging, communication, streamlining, real-time communication across specialties and hub and spoke centers. But what are your thoughts around pre-hospital? Do you think that that's something that AI can tackle? We know that there's still a delay from field to door. What are your thoughts on that? We'll start with Karen.
One of the ways that we leverage this is by educating our EMS providers, right? So understanding not to spend too much time on the scene, understanding how to communicate, and you can use Viz to communicate the symptoms that you're seeing. So, many different organizations, and I'm not going to call out one, use large vessel occlusion scales in the field, but the more education you can provide, particularly because across the country, sometimes we tend to be very focused on our own organization, but multiple organizations only have volunteer community EMS providers. So being able to share education, understand what it looks like, and when they need to move quickly, get out of the, leave the scene and get on the way and communicate the information about what they've found. So I think we can use that communication component absolutely to share that information from pre-hospital. And so we're not wasting any time. Time is brain.
Great. Thank you. Jayme, or anything to add?
Yeah, I think actually, we're already doing that with Viz, which is pretty exciting. So we have some challenges in Georgia. Karen, I'm sure you can relate to it from being in Atlanta and flying patients from all over and using the air evac crew, air Methodist and air methods and air evac. So we partnered with Viz to use Viz Pager. And actually what happens now is my neuroendovascular neurosurgeons they are able to generate and create a patient card like out of the Viz app and activate the flight team like when the patient's a go. So they're activating the Air Methods team right away. And then it creates this environment that they're able to communicate with the flight crew. So if anything changes, if anything, changes in patient condition or patient deteriorates or patient improves, we're able to get that information while they're en route. If there's delays, if we can't fly because of weather issues. And I think I saw Lisa Ziomex on, and she's doing the same type of work. We're actually partnering together to do research on the East and the West of how using Viz Pager can really help change that pre-hospital component of work. And we really struggled with door in, door out. I think when I came and we started working on really driving it down, we were like a 230-minute door in and door out. And through Viz Pager and with Viz and activating that flight team at the time of go and taking that into our hands, we are now down to, I think last month we hit 89 minutes of door in, door out, which was like pretty remarkable. Everybody said no way we'll ever get there, and we've made it. So we're already using it, which is exciting.
That's awesome. Congratulations. And Lisa says yes. She can't speak, but I'm going to say her yes for you. Wendy, anything you want to add to that?
So we're not using the Viz Pager at this point, but some of what we've been able to do is activate the race score and pull in the team. If we do communicate and do a lot of education and training with our EMS folks, and they've been really, really receptive and really good in identifying those potential patients that are coming to us beforehand. And, you know, we still use the old-fashioned radio or call in from them. We're working on some technology with another company to look at, you know, in the field and being able to notify us beforehand. But in the meantime, you know, basically taking that information and the diagnosis component of it on the RACE score and calling in our team or not. So they're here when the patient gets here, and instead of waiting for any type of CT scans or things like that. So we're doing some pre-notification, but we're not using the Viz app for that. But we might start.
Okay. Okay. Karen, anything to add to that?
Nope.
Okay, fantastic. So we're going to wrap up. We actually have one question that sort of brings things full circle to, you know, what I said in the beginning about all of you being prior clinicians. Somebody wants to know what motivated you to become hospital executives and what keeps you energized. So I'll start with you, Karen.
When you are a clinician and you're very passionate about what you do, people ask you to do more things. We all know that. That's nursing. We've been nurses from day one. If you're good at anything, you get asked to do more things. And I think the perspective, I know all of the women on this panel, including our moderator. And what has always driven us is our patients and our desire for them to have the best possible outcome, best quality of life. And so the decisions that we make from an administrative perspective just stem always from that perspective, from our patients. What we do is we now have an added layer, and what drives us as administrators is now we take care of the people who take care of the people. So it was very challenging for me to move away from being an advanced practice provider and being able to lay hands on my own patients to understanding that I could help more people by taking care of physicians, APPs, bedside nurses, CT techs, everyone, and making sure that they were motivated, that they had the tools and resources they needed to do their jobs, that they had the best technology so that they could provide the best bedside care. So that's me.
I love that answer. I couldn't agree with you more. Jayme?
Yeah, I mean, Karen kind of hit it right there. You know, I think, first of all, I don't think any of us start as nurses and are like, we want to be hospital administrators, like, and that's where we're going to end up, you know. But you really kind of evolve naturally. And I think all of us have been that way, and you evolve naturally. Like, you get put on committees, and then how about you become the manager? And then, okay, you're doing really good. How about you become the director? And you just evolve in your career. But at the end of the day, what drives me is the people that I work with and the patients that we take care of. And I think being able to be that person that's able to go get resources and support and anything that your team needs to take better care of patients is really what drives me and what keeps me going. And knowing that you're able to make an impact. I think when you are a clinician and a bedside nurse, yes, every patient life that you touch and every family, you're making an impact. But when you have a whole team and you're able to impact all of those individuals that then take all of the care of all these patients and all of the community, you're able to have a bigger impact and expand what you're able to do for patients, families, and your team.
Yeah, I know you all wear so many hats. Wendy, you as well. So what keeps you energized throughout all this and taking on more and more?
I know. Well, that's just who we all are, right? I think Karen said it best. It's like they just keep giving it to us and we just keep doing it because we love what we do. You know, being a healthcare administrator, I've been probably longer than the young ladies on here, but I started out as a clinician and it was hard for me to give up my patients as well. It was like, I even did it some, even while I was being director, even while I was taking on more leadership responsibilities. And it was really hard, but I was going up like the CEO track instead of like a service line track. And, you know, the next expected job for me is I was, you know, over neuroscience and rehab. And the next logical step was to be like a COO position. And so I went into that role. I had dietary, facilities, EVS. I still had neuroscience. I had cardiovascular. So I still had some service line. But I'm like, this is not my passion. I don't feel, I know I'm taking care of people who take care of people, and don't get me wrong, you know, the EVS were my best friends, right? It's like anytime you need something or you want them to check on a patient, they're right there. And same thing with dietary, because they're very important. But my passion was treating a neuro program or treating a neuro patient. And I didn't want to do that anymore independently, but I wanted to care for people and mentor those that were treating patients that wanted to, you know, to do that. A lot of times I get asked, like, how did you go from where you were to where you are? And I was like, exactly what Karen said. I just kept being a sponge, learning everything. I was over IT once. I didn't even know what, back then it wasn't even an IT department. It was like a guy in the back room with a computer and a tape that he taped every day. And I'm like, sure, because I just wanted to learn. And, you know, being in neuro all my career, you know, from the day I graduated from college to now, I mean, that's my place. That's what I understand. And I think we as clinicians speak more correctly with our providers, and they understand that we know clinical, we also know financial, and we also have to have that fiscal responsibility to assure that we just don't go overboard. But they have a tendency to appreciate us more than somebody who just has an MBA and really doesn't understand the clinical component, I feel. Not that, you know, I mean, I worked with some really good folks that are that way, but I think that for me, it's more of a personal relationship because they know that I know what they're doing and how that impacts care for the patient.
Yeah, no, I think you all said it best. I mean, number one, I applaud you obviously on all that you've accomplished and continue to accomplish. I think the fact that patients are our number one priority, and that we continue to lead the way, or you all lead the way on the next frontier of healthcare, which obviously AI is a big part. So I think in wrapping things up, I thank you and all the attendees for your time. And if you would like more information, you can go to our website at viz.ai or any of our social media channels. I hope everyone is safe and have a great night. And thanks so much for joining us. Thanks, panel. Thanks, ladies. Bye-bye.